Good evening, everyone. So, this week we'll be starting a new lecture series and we will start with the discussion about anti-nuclear antibodies. Now, in the subsequent weeks, we'll be discussing different kind of connective tissue disorders like SLE or systemic sclerosis, morphia, and all sorts. So, I thought before starting the discussion on each of these individual disorders, it will be helpful for us to understand the background of anti-nuclear antibodies because these antibodies will keep on creeping up in the background, so we need to have a somewhat of a clear picture about what do we mean when we say ANA is positive or anti-dsDNA is positive or anti-Smith is positive or ROLA is positive. So we need to have understanding what we are trying to say, how to interpret those reports, how to look at the titers, the patterns, how much importance to give to all of these reports. So I thought I'll begin first by discussing about the anti-nuclear antibodies, and then we can go forward and discuss each and individual connective tissue disorders in detail. So without much further ado, let's start our discussion on anti-nuclear antibodies. Now, they are known as anti-nuclear antibodies, but they are not necessarily targeted against only nuclear antigens. Other antigens like cytoplasmic antigens, other antigens like mitotic spindle antigens are also implicated. So antibodies against those molecules are also known as anti-nuclear antibodies. They are clubbed together under the umbrella term of anti-nuclear antibodies. But when we say ANA, when we say anti-nuclear antibodies, we don't mean only the antigens which are there in the nucleus. We also include antigens in the cytoplasm and the mitotic spindle. So there are a wide variety of autoantibodies. So that would be a better term instead of ANA, autoantibodies. And you have autoantibodies against DNA, RNA, mitotic spindle apparatus, cell membrane proteins, or even cytoplasmic proteins like ribosomes. Okay, so we term the total diseases as ANA diseases, in which the ANA levels or the ANA titers play an important role. We know it clinically as connective tissue disorders because most of these disorders have ANA positivity. But from investigation point of view, you can club all of these diseases as ANA diseases, in which you have increased anti-nuclear antibodies. Just remember that anti-nuclear antibodies can be against cellular antigens also, cytoplasmic antigens also, not only the nuclear antigens. Let's move forward. Now, ANAs are helpful for screening of connective tissue disorders. So when we say that get an ANA test done, so we are screening it. Okay, we are not diagnosing it on the basis of ANA. So any person who comes with an ANA positive report not necessarily has CTD. Okay, get this point very clear to you. Let me get this point very clear to you that if ANA is positive, does not mean that the patient has CTD. It has to be taken along with the clinical examination and the picture of the patient. ANA is just used to screen, and the levels are much more important than the quantitative positive or negative. Clear? So they're used to screen because they're highly sensitive for CTDs, because that's how we describe CTDs as ANA diseases. ANA can be false positive in multiple cases, for example, in case of infections, inflammatory conditions, neoplasms, or even in healthy population. Roughly about 3% of healthy population have ANA positivity as per the titers used in the lab. So ANA positive means nothing as long as you know the titers, as long as you know the clinical picture of the patient, and you take all of this into account while diagnosis CTD. So the interpretation depends on the clinical scenario, and you have to include the clinician while interpreting a report of ANA. Clear? Let's move forward. Now this is a very important table which I've taken from Kelly's textbook of Rheumatology 12th edition on page 869, and it tells you that ANA incidence or the nature of positivity of ANA is very high in SLE. That means majority of SLE patients will have ANA positivity. That is why ANA is a very important screening tool. If it's positive, then the suspicion of CTD is higher. If it's negative, the suspicion can still be there based on the clinical picture, and you need to go for specific antibodies. But if it is positive, then the chances of the patient having SLE increases. Okay. Similarly, ANA can be positive in systemic sclerosis, dermatomyositis, Sjogren's syndrome. When you have to look for autoantibodies which are specific for the disorders, you need to have certain antibodies. For example, antihistone antibodies, which are very specific for drug-induced lupus. Okay, so about 100% of patients will have that. Or for MCDDs, you have 100%, in 100% of patients, you will have ANA positivity. So you start with ANA, you screen, ANA comes out to be positive, the suspicion is higher, and then you look for specific autoantibodies. They can be useful for prognosis. Remember, ANA, the use is only screening, but in certain disorders, they can be used for prognosis, like in juvenile idiopathic arthritis or Raynaud's phenomena. In non-rheumatic disease like autoimmune hepatitis or primary biliary cirrhosis, you can have ANA positivity. So ANA can be positive even in non-rheumatological disorders. Clear? Let's move forward. Now, how do we detect autoantibodies? And that's a very important aspect to understand. The most important test, or the most common test that we use, is immunofluorescence. And immunofluorescence is considered to be the gold standard for diagnosis or to look for ANA. It is rapid, highly sensitive, and it's a good screening tool, screening method for ANA. Remember, if the ANA comes out to be positive, you do other tests to look for specific autoantibodies. In immunofluorescence, the serum is tested at serial dilution. You keep on diluting, and that's why you get report as 1:20 or 1:40 or 1:160. So these are all dilutions. That means it has been the serum has been diluted about 20 times, 40 times, 160 times, and still turning out to be positive. Clear? The substrate which is used is cultured Hep2 cells, and this could be a good Viva question or a good question in a quiz, that a substrate used for immunofluorescence is cultured Hep2 cells. And cultured Hep2 cells mimic human cell lines. So you don't use animal substrates like monkey or any other animals. You use the human cell line, which is the Hep2 cell line. Results has to be interpreted into two parts. What is the pattern of immunofluorescence and what is the titer of immunofluorescence? So these dilutions or ratios that we say are the titers. While pattern is homogeneous, speckled, rim, so these are patterns. So how much in what dilution it is positive tells you the titer, and in what pattern, what distribution it is positive in the cell tells you about the pattern. So most of the labs consider more than 1:40 is positive, more than 1:40. But the more the dilution, the more the specificity of the test increases. For example, if you consider more than 1:160 as positive, then it is more specific to connective tissue disorders, but it becomes less sensitive. If you want it to be more sensitive, you can take it as more than 1:20 that we usually do in clinics. We take 1:20 or more as positive, but it's better to use a higher titer. It's better to use 1:40 or 1:160 as the threshold of titer. The higher the titer, the highly specific ANA becomes. Okay, but remember, ANA has high sensitivity, so it's better to use it as a high sensitive tool to screen and then go for specific antibodies. Okay. The second method is ELISA. There are two types. You have generic ELISA or you have antigen specific ELISA. In generic ELISA, you have a broad specificity. You look for any antinuclear antibody and the specificity is same as immunofluorescence ANA. For antigen specific ELISA, you look for specific antibodies. That means against dsDNA, against SSA, SSB or SCL70. So you look for specific autoantibodies. In antigen-specific assay, you can use multiple antigens which can be coated on different wells of the plate, and then you can see which antibody is coming out to be positive. So you can have multiple well. One is coated with dsDNA, other is coated for Smith antigen, other is coated for SSA, and you can see which well is showing positivity at what titer. It is highly specific and sensitive. It's quick, simple, automated, and the sensitivity and specificity as compared to immunofluorescence is very good. It's about 69 to 98% sensitive and about 81 to 98% specific, depending on what kind of ELISA you're using. Different tests have different sensitivity specificities. So you screen by using immunofluorescence for ANA, and then you look for specific antibodies using ELISA. Clear? Now, We have discussed in the previous slides that ANA reports are interpreted with the titles and patterns. So we'll learn about them now. The pattern, when we say pattern, we mean how the antibodies are localized inside the cell with respect to their autoantigens. So you have a cell and you have a nucleus, whether the antibodies are, inside the whole of the nucleus, or they are in a speckled pattern in the cytoplasm, or they are at the around the nuclear rim. So how they are localized, how they are placed inside the cell tells you the pattern. There are about 30 distinct patterns, out of which 14 patterns should be reported. The patterns have been grouped for understanding as nuclear patterns. So inside the nucleus, it can be homogeneous, diffuse throughout, speckled, dot-like, dense, fine speckled, so they are thicker dots, densely packed, or discrete nuclear dots in which you have, thickest dots, bigger dots, you can actually count easily, or nucleolar. That means staining only the nucleolus. Nucleolus is inside the nucleus, okay? Second is cytoplasmic, in which you can have fibrillar, speckled, rods, rings, or rim-like. All these patterns are there in the cytoplasm of the cell, not the nucleus. Or you can have against the mitotic apparatus like mitotic spindle, etc. None are disease specific or pathognomic. So there's nothing like you are saying a homogeneous pattern, so it is this disease. The probability of having the disease increases. The chances of having that disease increases. The chances of the test pointing towards that disease increases, but they're not pathognomic. That you see this pattern, it is 100% that. No, you have to interpret it depending on the titers and the clinical picture of the patient. The type of the disease associated autoantibodies is important. For example, if a patient has, let's say you're suspecting drug-induced lupus and the antihistone antibody comes out to be negative, then there's a very high chance that the patient doesn't have drug-induced lupus. But the patient can still have drug-induced lupus, it's just that the test is showing negative. Okay, so you need to interpret pattern and titers while looking at the reports, and then you have to look at the reports by keeping the patient in mind, collect all of this data together and make a diagnosis. Now, after discussing patterns, we'll show you the pictures of patterns while discussing the diseases. So after discussing the patterns, we'll discuss about the titers. So titers are directly proportional to antibody concentration. More the antibodies in the patient's serum, higher is the titers. So imagine that if a patient's serum has high amount of antibodies, you will have to dilute it to a larger extent that it will show positivity. Okay, so if you dilute it further, the test will be negative. The more diluent or the more weaker the serum becomes, it will turn out to be negative. The moment it turns out to be negative, the last positive dilution is the dilution of the test. So if 1:160 is positive, that means that the serum was diluted 160 times and still showing positivity. Any further dilution would be negative. In that case, the patient's serum had large amount of antibodies that you had to dilute it 160 times and still it is showing positivity. So higher the dilution, higher the antibody concentration. Clear? So large dilution at which the ANA pattern is detectable is the positive dilution. So it can be 1:40, 1:20, 1:160 and all sorts. Okay. Normally, 1:40 is considered positive, but as I said, higher the titer, the more specific the test becomes. So 1:160 is significant. If a patient comes with ANA positive 1:160 or more, that means ANA is significantly positive. If it is about 1:40, 1:20, then it can be false positive or positive because of other reasons. In milder symptoms, it can be negative. The patient's serum doesn't have enough antibodies to show a positive reaction. So immunofluorescence against the autoantibodies is the gold standard, but remember it can also cross-react. Okay, about 32 normal population, 32% patients of 32% of normal population can have positive if the threshold is 1:40. Okay, ideally it should be less than 5%, but if the threshold is 1:40, about 1/3 of the population can show false positive reactions at 1:40. So higher the threshold, higher the specificity, but lower the sensitivity. Clear? Let's move forward. So with the background about anti-nuclear antibodies, we'll start discussing the relation of ANA with specific diseases. We'll majorly focus our discussion on SLE and systemic sclerosis, and then we'll go further while discussing each and individual diseases in further lectures in the series. So ANA is anti-nuclear antibodies. That means antibodies against the nuclear proteins. If there are antibodies in the system, in the body, then they will attack the antigens and destroy the cell. More the antibodies, more the destruction of cells, more the inflammation. So more the ANA, more is the inflammatory effects. So ANA is directly proportional to pro-inflammatory effects. Clear? Any antibody when bound to their respective antigen will cause inflammation. That is how immunity works. If they are autoantibodies, they will bind to autoantigens and inflammation will happen. One of the specific most antibodies that we learn about is anti-dsDNA antibodies, which is specific for SLE, and it promotes inflammation, increased chance of nephritis, immune complex deposition, because it binds directly to glomerular antigens. That is why it leads to more nephritis. So we can see that if you have specific antibodies against specific antigens, you can clearly say that the person is suffering from a certain CTD. For example, anti-dsDNA is positive in higher titers. SLE is somewhat confirmed. In fact, you require these antibodies as per the ACR criteria. There are many antibodies, anti-dsDNA, anti-Smith. So these antibodies are required as a requirement of the criteria to diagnose SLE or any other CTDs. But the issue is that ANA doesn't correlate well with longitudinal follow-ups. So if after treatment the ANA is not going down, it could be because the disease is still active, or it could be just because ANA test is showing positivity. So ANAs are not better used as a follow-up marker. You don't have to treat the patient till ANA comes out to be negative. You have to treat if the symptoms resolve, the symptoms are in control. You can use ANA to diagnose, they are very sensitive. You can use ANA for diagnose, but they are not that helpful to follow up for the patient. Clear? Let's move forward. Good evening everyone. I hope you're enjoying this video, and I've come again to ask you to vote for Delhi for Dermacon 2028. So with the support of IDBL Delhi State Branch, do vote for Delhi and come and meet all the dignitaries here, and let's have a good academic discussion in the backdrop of the cultural heritage that Delhi offers. So enjoy this vibrant city that I duly call my own, and if you follow this instruction to become an e-voter, you can just easily vote on the IDBL website. It hardly takes less than a minute, and it's better to vote as early as possible. Will help you in tackling all those spam calls that you get. So make sure that you choose Delhi as a good venue in 2028, and let's meet there. I shall see you in Delhi. Bye bye. So let's start our discussion of SLE with the background of our knowledge about anti-nuclear antibodies. ANA is positive in about 96 to 99% of SLEs. We know that it is highly sensitive. But if you want to go specific, you have to look for anti-dsDNA antibodies. These are antibodies against the nucleosome or chromatin forms of DNA. That means the unwrapped large strands of DNA, not the condensed chromosome. Okay. It is highly specific for SLE. The specificity is about 97%. Associated with nephritis because of immune complex deposition in the nephrons, correlates well with disease activity, and it can be positive in drug-induced LE too. So remember that in mind. But drug-induced LE, if you want to diagnose drug-induced LE, you have to look at different antibodies like anti-single-stranded DNA or anti-histone antibodies, in which anti-histone is very specific for drug-induced LE. It has low diagnostic value. Remember, diagnostic value ANA is better. Okay, but it has a good predictive value if the clinical suspicion is high. If the clinical suspicion is low, even a positive anti-dsDNA is not that helpful. So if a person comes to you with systemic sclerosis symptoms and you see anti-dsDNA positive, doesn't mean that the patient has SLE. The patient can still have systemic sclerosis, but it's just that the anti-dsDNA is positive. Clear? Let's move forward. Other antibodies are anti-small nuclear ribonucleoproteins, which are the anti-Smith and anti-U1 snRNP. These are against RNAs or against spliceosome proteins. So spliceosomes are, apparatus in the cell membrane that is required for splicing up the mRNA when the mRNA and RNA proteins, RNA particles, when they are getting, multiplied or translated and transcribed. Since it is uridine rich, that's where the letter U comes from. Out of these small nuclear ribonucleoproteins autoantibodies, anti-Smith autoantibodies is highly specific for SLE. So after anti-dsDNA, we have anti-Smith autoantibody, which is highly specific for SLE. The U1 SLRP is not so specific. So anti-Smith is another antibody or another autoantibody specific to SLE. But you have to keep clinical correlation in mind. It has to match the clinical correlation. Other antibodies like anti-Rho or anti-La can also be positive in SLE. They are more specific for Sjogren's, but they can be positive in SLE. Anti-Rho is against three antigens, Rho60, Rho52, and E3 ubiquitin ligase. They are specific for they are seen in SLE and neonatal lupus syndrome. So this is very important. Anti-Rho or SSA is seen in patients in which you can have neonatal lupus syndrome. Clear? Other CTDs are Sjogren's syndrome, systemic sclerosis, inflammatory myositis, mixed connective tissue disorders, or multiple connective tissue disorders. Okay, rheumatoid arthritis. But it can be positive in disorders which are non-rheumatological, like primary biliary cirrhosis or even liver cirrhosis. Okay, it can be the anti-Rho can be the first ANA detected preclinically. So before even the clinical symptoms appear, you can have positive anti-Rho. Talking about anti-La, it's against the proteins which are required to form RNA polymerase transcripts such as tRNA or translocation of some mRNAs. You don't have to remember anything. Just remember that anti-Rho is seen in neonatal lupus syndrome, SLE, Sjogren's syndrome, and anti-La is seen in Sjogren's syndrome and SLE. Clear? Let's move forward. Antihistone antibodies. Now, antihistone is against the histone apparatus or the nucleosome. They're against the nucleosomes, which are the protein substructures of inactive chromatin. So when the DNA is in large strand, they're collected into short bundles known as nucleosome. If the antibodies are against those bundles, then it is known as antihistone antibodies. Now, antihistone is specific in drug-induced lupus. So if that comes out to be positive, the symptoms are of drug-induced lupus, you have a suspected drug, it is drug-induced lupus. Clear? So clinical suspicion is better because some of the recently implicated drugs are showing lower frequency of antihistone positivity. So clinical suspicion is a better guide for drug-induced lupus. So here's a collection of all the patterns that are seen in SLE or somewhat specific for LE. In homogeneous pattern, you will see a homogeneous staining of the nucleus seen in anti-dsDNA, antihistone. In the cytoplasm, you will see cytoplasmic stainings as in ribosomal P or anti-tRNA synthetase. In nucleolar coarse and dense pattern, you will see only the nucleus pattern staining with coarse and dense as the distribution of the staining. Whenever I say stain, I mean fluorescence. So I'm sorry, I'm talking the histopathological term, but in immunofluorescence, I'm talking about fluorescence. So if the fluorescence is coarse and dense, you can see in anti-Smith, U1 SNP, anti-RNA polymerase 3, or if it is fine or speckled, you can see in anti-Rho, La, Mi2, Tiffy, Co. In this cytoplasmic fine speckle, you can see in anti-Jo1 or the nuclear dot pattern in the nuclear matrix protein. Clear? So this is how the patterns look under a microscope. And if you have an ANA report, it usually mentions the pattern. Actually, it has to mention the pattern also. So next time, look at the titers and look at the pattern and try to make a diagnosis in interpreting the report. Let's move forward. Now, discussing the second disorder, systemic sclerosis. In about 95% of patients, ANA is positive. So ANA is very highly positive, just below SLE. Clear? But you have to look at different specific autoantibodies, that is autoantibodies against the centromere protein, against the topoisomerase 1 or against the RNA polymerases. Clear? Discussing first the anti-centromere autoantibodies or anti-kinetochore antibodies. These are against the centromere or the kinetochore macrocomplex. and requires actively dividing cell for detection. See, when the cell is in interphase, the chromatin is just diffusely threads and few histones as a sequestering mechanism for the chromatin. When the cell starts to divide, the DNA starts forming chromosomes and dense chromatins. When dense chromatins are forming or they form chromosomes, you will have the formation of centromere. If centromere forms, then only you will have autoantibodies for centromeres. So you need, if you want to check for antibodies against the centromere, the substrate that you are using need to have centromere. Only then the antibodies will react to centromeres and show fluorescence. So you require actively dividing cells so that you can have some centromeres in the substrate, and when the centromeres are there in the substrate, the antibodies will bind from the patient's serum, will bind to the centromeres and show immunofluorescence. Clear? They're specific for Raynaud's phenomena and the crest. Let's move forward. Anti-topoisomerase 1 or SCL70 is against the catalytic region of DNA helicase topoisomerase 1. It does not require mitotic activity. So with the previous autoantibody, we told you that it requires actively dividing cells. Anti-topoisomerase 1 doesn't require actively dividing cells. It is seen in diffuse cutaneous systemic sclerosis with proximal skin involvement and also with the interstitial lung disease. Clear? Let's move forward. Anti-RNA polymerase autoantibodies are against the eukaryotic RNA polymerase 1 to 3. And these are very specific for systemic sclerosis. Okay, they are seen in rapidly progressive skin disease, joint contractures, renal crisis in systemic sclerosis, gastric antral vascular ectasia or GAVE, and also in malignancy in SSC. So if this autoantibody turns out to be positive in high titers and the patient has systemic sclerosis, the chances of malignancy also increases. So you have to screen for that too. Now, these are the patterns that has been described in Kelly's textbook of rheumatology, which I have used here. In the anticentromere one, you can see that in some of the cells, the immunofluorescence is at different sides of the nucleus. Why? Because now the chromatin is condensing and forming dense chromatin about to form chromosomes, and you have the formation of centromeres, and anticentromere autoantibodies can bind to them to show inflorescence. In some of the cells, you don't see these two different parts. In other cells, you just see speckled part. So this is the anticentromeric localization of autoantibodies. And we require actively dividing cells for that. So the substrate needs to have actively dividing cells. But for DNA topoisomerase 1-like pattern, in which you have the anti-SCL70 antibodies, you do not require dividing cells, and you see it more as a diffuse staining, but you have certain localization. If you look carefully in different cells, you have localization of immunofluorescence because they are localizing against the DNA topoisomerase. And that is how you see the topoisomerase 1-like pattern. In homogeneous nucleolar pattern, this is not the nuclear pattern, it is the nucleolar pattern. So you have a nucleus, and inside the nucleus you have a nucleolus. So you see the nucleolus, and this entire is the nucleus. So it is nucleolar pattern, homogeneous staining of nucleolus, nucleolar pattern. A clumpy nucleolar is not homogeneous, it is clumped like. So same as before, it is staining the nucleolus but not homogeneously as a clumpy pattern. So this is clumpy nucleolar pattern which is seen in anti-U3 or antifibrillarin autoantibodies. Let's move forward. Now, we must discuss what are the reasons for false positive ANA. We might have a report of positive ANA, but the clinical symptoms are not matching. So you need to know where ANA can be false positive. It can be positive years before the manifestation happen. So if the positive report is today and the patient may develop CTD in the future, so it can come positive before clinical symptoms also. So that's one reason. It can be positive in about 3% general population, healthy individuals. So that's another reason. Other reasons for false positive reports can be that low titers were used. It was not diluted properly. Other autoimmune disorders like autoimmune thyroiditis, GI disease or liver disease can show ANA false positivity. infections, and malignancies can also show false positive ANA. Similar to false positive ANA reports, we have false negative ANA reports. Now, we have discussed that row 60 and row 52 can be false negative because during the preparation of Hep2 cell line, these antigens can be washed off. And if you don't have antigens in the substrate, you don't have anything for the antibodies to bind, and the test can be false negative. Other reasons for false negative can be inappropriate testing. The testing was not done properly, errors by the lab, variable test because ELISA if you have used IAF, you use ELISA, what type of ELISA, what type of substrate. So it depends on a lot of different factors. It can be positive for specific anti-nuclear antibodies. Remember, we have discussed in the case of anti-Smith antibodies or anti-Rho or anti-La antibodies, which can be positive in ANA negative SLEs also. So if the ANA is negative or test is negative, patient can still have CTDs. If the clinical suspicion is high, go for specific autoantibodies. If the patient is taking immunosuppressive treatment, then also the reports can be high. Hi, hope you're enjoying this video. I know it's a long video, so I thought I'll give a certain break after listening to such a long videos that I make. If you think that these videos are helpful in your residency, do consider becoming a member. You can opt for Sapphire membership or Ruby membership. I would prefer it to be a Sapphire membership, of course. You get access to longer videos, bonus contents, extra information to make things more interesting, and to cover each and every aspect of the topic that we are discussing. Okay, so I think that's enough of a break. I should continue with the video, and you should listen to the other person at the bottom right corner tell you different topics of dermatology, venereology, and nephrology. That being further said, let's continue with the video. So this is the complete flow chart which is given in Kelly's. I have added another box for anti-histone. The Kelly one doesn't have a box, so if you want, you can take a screenshot of here, and you can rapidly, find it out. Rapidly go through this flow chart, and it will help you in interpreting or requesting for anti-nuclear antibodies and specific autoantibodies. Clear? Now this is another flowchart, looks very complicated. I'm not going to explain it, but it is essentially saying the same things that we have discussed in the previous flowchart, that how to go about if ANA comes out to be positive and if your clinical suspicion is high or low, or if it comes out to be negative and the clinical suspicion is high or low. So I'm not going to go into detail of this flowchart. It looks complicated, but it's very easy to understand if you have understood the previous one. I'll wait for some time so that people can screenshot it, and then you can read. Otherwise, read this article. It's a very good article. It will be in the description. Copy paste it and look at the full text and read this article. It will help you in understanding anti-nuclear antibodies. So with that, I've made this table. It's a very painstaking effort. It took me a lot of time to understand and summarize important points. So in this table, I have put all the anti-nuclear antibodies, the target of these autoantibodies, and the diseases for which these autoantibodies are specific for. Okay, so if you want, take a screenshot, put it in your phone so that you can revise, or you can look at it or refer to it whenever you want to do. So I would like to send my thanks to one of my closest friend, a very dear friend of mine, Siddharth. He's a rheumatologist by profession. He's working as a faculty, and he helped me a lot in understanding the anti-nuclear antibodies and the intricacies of ANAs and what to do when what not to do. And he gave me good reference articles which were very, lucid in explaining the importance of anti-nuclear antibodies. And whenever I have any issues with connective tissue disorders, he's the go-to person, and I disturb him at every point of time while discussing CTDs. And all thanks to him. And these are the further reading recommendations. If you want to learn more about ANA patterns, you can go to anapatterns.org. This is the chapter that I've used in Firestein and Kelly's textbook of Rheumatology 12th edition. These are some individual articles. They will be there in the description. You can copy paste and read this if you want to know more about anti-nuclear antibodies. They are very interesting to read about if you have the time. Again, requesting to become a member of the channel. You can become a Ruby member if you like these videos, or if this video or all these videos that I'm putting on my channel help you a lot, then do do consider becoming a Sapphire member. It's a tier above Ruby member, and I don't wish to continue Ruby member for after a few months. I might have to discontinue Ruby membership. But Sapphire members have certain perks, and you can look at the members only videos, which are only for specifically for Sapphire members. I've been putting on and off one or two videos, some extra videos, extra stuff only for the Sapphire members to see. With that in mind, I would like to finish this week's lecture on anti-nuclear antibodies. I hope I was able to make anti-nuclear antibodies a bit simpler to understand. Even if you have not understood anything, you can use this video to refer back again and again. You can click on the chapters present in the description, and whenever you admit a patient of connective tissue disorders, learn about the anti-nuclear antibodies, and with time you will be easily able to remember why you have to do ANA first and then anti-dsDNA, and what all autoantibodies have point towards the probability of different kind of complications in CTDs. So without much further ado, let's finish this lecture. It's already quite long, but with the background of anti-nuclear antibodies, we can begin a lecture series on connective tissue disorders. Adios and bye bye.